first of all, sorry for the long title, but that's basically my PhD thesis title. So before starting, I would like to thank you, my main supervisor, co-supervisor, and my PhD collaborator in this project. So Medica, Momadik, Sherstiengan, Katinka, Dedikurz, and Liv Juren Hollisley for helping me and in this long journey. I would like to have like a small overview of what I'm going to present, because there might be some topics that they're going to just mention briefly, while other I'm going to go more into details. So my research is about cerebral stroke with CT perfusion as image modality. So I'm going to talk about that as a background to actually for you to know what's my work is based on. And then I'm going to talk and present the approaches that I've been working on in this journey. For you to understand, a cerebral stroke is the first leading cause of disability-adjusted life years and the second leading cause of death globally, according to the World Health Organization. It has a huge socioeconomic impact on society and a tremendous impact on the quality of life for every single patient. So these are the fundamental reason why we actually working and dealing with this medical condition. Specifically, we focus our work on ischemic stroke, which composed approximately 80% of all the cerebral strokes. And moreover, we focus on acute ischemic stroke, which is the early stage of an ischemic stroke. So we focus on the few hours from symptoms onset of the stroke that so after the stroke happened, we focus on the first 4-5 hours of the stroke. For you to know, I mean, I'm not going to go into details on this, but for you to know, ischemic stroke, it happened when a blood clot occlude an artery in the brain and prevent the blood flow to normally flow in the tissue, in the brain tissue. This cause an ischemic region to create. And this ischemic region can be divided in two subregions, which are called penumbra and core. The core is the irreversibly damaged area, basically that tissue. And penumbra is an area where the tissue is still vital, but critically hyperperfused. Medical doctors try to understand, to assess these two areas because they want to know fast how damaged is the brain tissue, how much of this tissue can still be salvable. So they want to understand as fast as possible these two areas. So at Stavanger University Hospital, patients with suspect acute stroke are investigated by CT perfusion, which is an image modality that is formed by acquiring 3D CT scan of the brain at many time points during the injection of a constant agent to highlight the flow of the blood inside the brain. So just for you to understand what are we using and what are we dealing is 4D data, so a 4D tensor, where we have a 3D volume of the brain over the time of this constant agent being injected and wash out from the brain. So a single patient study contains a lot of information and can be defined as a 4D tensor with these 4 dimensions are time, height, width, and depth. And based on that, medical doctor cannot just look at this huge amount of information. So what they do is create, based on the vendors that the CT scan is used, they create parametric maps. As you can see here, parametric maps contains more dense information than the previous CT perfusion scan. And these maps are generated based on a density curve that you can see on the left. So each pixel is analyzed with this density curve that simulate the actual wash in and wash out of the constant agent inside the brain over time. So this density curve is like a time and in the x-axis, and the y-axis is actually taking into consideration the enhancement or how the intensity pixel level are in that particular second or in that particular moment. So these parametric maps contain information, useful information for medical doctors to look at, to understand and to assess the ischemic region, so penumbra and core. Our objective for the PhD, for my PhD, was actually to delineate an automatic and accurate segmentation methods for these ischemic areas using AI. Could be machine learning, could be deep learning, or could be with supervised or self-supervised approaches. And one main question that we addressed was, is it better to utilize the entire spatial temporal information from the CTP scans, or the color code generated parametric maps are good enough for this task? For you to understand a little bit more, this is the pipeline of a very brief and simple pipeline of my PhD. So on the left, we have our inputs, could be a 4-dimensional input that goes through some pre-processing steps, going to mention later, or we can have an input that generated color code parametric maps. Based on these two inputs, we developed different methods, could be supervised or could be self-supervised. Just for you to follow up also in the next slides, the data set is composed of 3 different groups, patient groups. These patients are divided in large vessel occlusion, non-large vessel occlusion, and without ischemic stroke patients, which means for you to understand is large vessel occlusion is if a large vessel is occluded by this blood clot, create a very large ischemic area. A non-large vessel occlusion create in theory, a smaller ischemic region, and the without ischemic stroke is patients that were suspected of a cerebral stroke, but they came to the hospital at the initial CT scan to actually assess the damage, and then they turn out not to have like a cerebral stroke. So we have this real life scenario where the non-large vessel occlusion group is the most common, while the large vessel occlusion is the one with the most clinical significance because contains a lot of information or a lot of the brain tissue is damaged. So we can work on that. And also we have some patient that does not contain any damage area. So we can actually have like, we are not forcing the model to always predict some damage area. Two expert neurologists created this annotated our data set based on the parametric maps and other image modality in order to have this multi-class data set. As I mentioned before, we perform some pre-processing steps on our data set in order to go from the raw CT perfusion scan to actually something that might be more visually appealing. So from the CT perfusion scan, we extract the brain with the public available algorithm. And then on the extracted brain, we use some content enhancement algorithm to actually highlight better the wash in and wash out of the constant agent. Okay, so first thing that we try to do is a supervised approach. So we try to understand if classical machine learning or deep learning algorithm can actually help us in this to tackle this segmentation problem. As a brief mention, I have 4 publications on this regard, so in this supervised approach, and I'm just gonna talk about a little bit more about those. So first paper is we use CNN-based segmentation using the entire 4-dimensional CT perfusion scan as input to our model, to our deep neural network model. There is no parametric maps involved in the pipeline, and we segment core and penumbra regions. And this is just used as a proof of concept because we use a very small data set, so it's just like 10 patients, and to just try to understand if this approach might work or not. So the pipeline is easy. The pipeline is straightforward because instead of passing by the calculation of the parametric maps, we try to avoid that. We try to just focus on the CT perfusion scan. We perform some pre-processing. We use a deep neural network to actually have like a multi-class segmentation output out of that. Since the data set was small, we had like a problem of the input size. So instead of using the entire dimension of a scan, so the entire height and width of each image, what we did is using a Windows slicing approach. So we have like a small patch of each, like a patch size of 16 by 16 window size, and then we just create like a large number of these tiles that goes through the scans, the CTP scans, and we create our input of 16 by 16 times the number of time points. So we have like a very large amount of input for that, for our model, and we create an output of just 16 by 16. So we just try to focus on the temporal dimension here. As you can see on the right, the model, the architecture is very similar to a UNet structure, a classical UNet structure, while the first part, the convolutional part, the first 3 or 4 layers of the model are just used to analyze the temporal dimension of this input, 2D plus time input, and reduce the input to actually being able to be convolved and encode into the UNet structure. Results are okay-ish, in the sense that the model is able to understand, based solely on the four-dimensional CT perfusion, the actual area where do we need to focus, or how the brain tissue is being damaged, just basically looking at the CT perfusion scans. But at the same time, since we're using this patch size, there is a problem that the prediction that you can see on the bottom row are pixelated. So there is some understanding of the regions, the different regions here, but the pixelated part is actually something that's not very visually appealing. So what we're trying to do is try to improve that this part. But before doing that, we thought, okay, we know that deep learning or deep neural network, supervised deep neural network work. Why don't we try to use machine learning algorithm? So we take a step back in that sense. And also, why don't we use parametric maps for doing that? So the second paper used parametric maps as input, and we use classical machine learning algorithm to try to segment these ischemic regions, again, both core and penumbra. And we tried to compare this classical machine learning algorithm to the thresholding approach from the literature, which is something that normal research have been done for decades. The overview of this paper is a little bit more complex than before, but basically we using the input feature are actually our parametric maps, the generated parametric maps. And what we're trying to do with that, we use SMOTA, which is a synthetic minority oversampling technique, to augment this feature. So we try to to combine this input feature from the parametric maps, and we try also to augment these images or these features. Moreover, we try to use SLIC, which is simple linear iterative clustering algorithm, to generate supervoxel that might help the model understanding the spatial information of the regions. And moreover, at the end of this approach, at the end of this machine learning algorithm, we used as a post-processing step a 3D mode filter to smooth out the prediction. As you can see here, there are 2 different approaches, a single step and a 2-step approach. because what we try to do is we try to follow medical doctors perceiving of how to deal with this medical condition. So what they do normally, instead of looking at all the parametric maps, they focus on 2 parametric maps, as you can see on the bottom left of the figure here, the CBF and CBV, for understand where the core is, so the dead tissue here. So there are parametric maps that actually only involved for this kind of ischemic area. And then there are other set of parametric maps, such as the Tmax or TDP or MIP, for understanding where the penumbra is. So we try to divide them. So we have like 2 binary segmentation approaches. So one to define penumbra, one to define core. And then we have a logical combination under medical constraint to combine the prediction, because as a constraint, the core needs to be inside a penumbra region. So if the first model, the step 1, the first model does not predict tissue as penumbra, we just exclude that in the core prediction. Then we do, so that's why we use this logical combination. Then we do again a 3D mode filter, and then we have like a multi-segmentation, multi-class segmentation output. On the other hand, the single step approach used, instead of just dividing this set of parametric maps, we use all of them, because we think that the model is can learn different feature even from all the parametric maps. So it might be better for the model to use the entire set of parametric maps to have like a multi-class segmentation. So we don't have any logical constraint here. We just feed the entire input feature to the model. We have done a lot of experiments, and we are trying to use different combination of what we have proposed. So we can use different machine learning algorithms, such as decision tree, random forest, or support vector machine. And we also try to use different input feature set, such as just the parametric maps, just a super version of the super pixel version of the parametric maps, the combination of them, the parametric maps plus the augmented version with SMOTE, or a combination of these. So at the end, we have 30 experiments, a set of 30 experiments, and I'm not going to bother you with a lot of data here, results, but we saw that the model with a single step approach, so everything fed to the single machine learning algorithm, which was the random forest, with super pixel and parametric maps as input, yields the best results in order for DICE, for both the region, for DICE and precision, and also yields a very low difference in the volume, and the predicted volume. So that's the one that we use as our proposed best method, which is shown here in the table. We compare that model with a default setting of our vendor, which is the one we use CT Perfusion CT scan made by Siemens, and the parametric maps are used based by this vendor called Singovia, again from Siemens, and they have a default setting to define where these penumbra and core regions are. So we try to compare our best model with the default setting, and also we try to compare that with some other literature research paper. They use thresholding approaches, and we saw that our method is really good, or it's better to segment penumbra in large vessel occlusion patients and in non-large vessel occlusion patients, but it's not as good or as accurate to define the core, which is a very small area in the brain tissue. So as a visual results, you can see here a large vessel occlusion patient on the left and a non-large vessel occlusion patient on the right. And you can see actually the ischemic region are the one defining in light gray and white. So you can see actually a visual difference between a very large area in the large vessel occlusion patient and a ischemic area in a non-large vessel occlusion patient. So there is still work to be done here. And what we're trying to do is to continue on this path. And instead of using machine learning, we used deep learning in another paper that we create. So again, a set of parametric maps as used as input, and we have a convolution-deconvolution bottleneck architecture with multi-input and slow fusion approach, and we use a focal twerk index loss as a function. Again, this is the general overview. We use parametric maps as input. We have each input image goes through a VGG16, and then we concatenate the feature at the low level and the layers. And then during the deconvolution part, we slowly concatenate all the different feature extracted in the convolutional part by every intermediate and upper layers. We used a transfer learning approach because there were other papers in the literature that were trying to do the same. So we thought, okay, might be a really good approach for us as well. We used the layers from the VGG16 were pre-trained with ImageNet dataset, and for the class imbalance, which was, as you can see before from the visual results from the previous paper, of course, we have, as in any medical domain, we have class imbalance because the ischemic region or the one that we focus on are really small compared to the overall picture. So we focus on the non-large vessel occlusion group, and we also use this loss function that I mentioned, the focal Tversky loss, which is a generalized dice coefficient loss, which 3 parameters that can be optimized, and the parameter are these alpha, beta, and gamma. We perform again a lot of experiment with a hyperparameter optimization, a different combination of the inputs, a different way to set up the layer weights, and we also compare with the slow fusion and early fusion approach in the how to concatenate the information. To summarize, as you can see here from the table, and it's not very novel, but the layer weights, we try to have like a gradual fine-tuning approach on how to deal with the weights in the layers, because we check if we keep all the layer frozen in the VG16. We also check if we all keep the layer unfrozen, but we're also trying to use like a more gradual approach where the layer were slowly unfrozen based on the check on the validation loss during training. So we noticed that this slow fusion approach with gradual fine-tuning using parametric maps and meta information from the patient, the one highlighted in red on the second last row here, was the one that actually achieved the best results. We also compare our slow fusion approach on the left with early fusion approaches, where for example, we have early fusion approach where the structure is the same, but the input are concatenated, the set of parametric maps are concatenated over the channel axis. So instead of using 4 or 5 VGG16 architecture, we only use a single VGG architecture that takes in as input these concatenated parametric maps. Also, we're trying something similar, which we call early fusion with inflation, where the input are concatenated over a 4th dimension, and the VGG16 is only one VGG16, but it's inflated 3D VGG16 inspired by the paper from Carrera, the one COVID action recognition, where they introduced video classification model with an inflated ImageNet pre-trained architecture. So the filters and the pooling kernels are remodeled from square to cubic filters here in the VGG16. But even with this early fusion approach, we noticed that our proposed model is still better, both in the prediction and segmentation of penumbra and core, and also it's better even in the different groups that we analyzed. We also have tried to have like an inter-observer variability results where the model is compared against 2 neuroradiologists that annotate our whole test dataset. And we see that the results from this model are pretty similar are not exactly the same, but we see that there are some similarity between our prediction model and the comparison of two different neuroradiologists. Visually, the results look good. The prediction are in light gray and white, while the ground truth are denoted by the neuroradiologists are in blue and red. So you can see the results are pretty good, but they're not perfect, because as you can see here, there are some false positive prediction based on the parametric maps. We think it's because of the parametric maps, how they've been defined, and there might be some problems during the creation of the parametric maps. So what we decided to do is go even further. So we tried to explore, as in paper 1, that we tried to explore the entire 4D CT perfusion scan for segmenting this area. So we tried to develop a novel 4D convolutional layer for processing the data, the 4D data efficiently. We create a deep neural network model for predicting ischemic area from the 4D CTP data, and we try to use spatial temporal information that improve the model performances. In order to do that, we tested 7 different approaches. I tried to go fast in here because honestly, there are a lot of approaches here. So the first approach is the one proposed in the previous paper. So the one where we have the parametric maps as input. From the approach 2 to the approach 7, we used instead CT perfusion, so the 4-dimensional CT perfusion scans. Again, they pass through the same pre-processing steps. The second approach is the one defined in paper 1. So we have a 2D plus time in volume, where we have height, width, and time as the input of our model. So we have like this 3D volume. Approach 3 follow the similar structure as before, but this is based on a research group from Alberta, and they use this network called temporal convolution network, where we have each individual time image in the time points is treated differently by an encoder, extract feature in the low dimensional space, concatenate together in this TCN network, and then they combine the output to be decoded into a single decoder. They have proposed this 2D temporal convolution network. They also propose a 3D temporal convolution network with a single encoder, which is the one on the top right of the figure here. But we also try to exploit this architecture with multiple 3D encoders. So here, again, we have the time points treated separately, but at the same time, we take into consideration the neighboring slices of the scan. Another approach that we propose is called 3D plus time MJNet, which is an extension of the first paper, where we have the current 2D plus time volume is treated as an input together with the neighboring volumes of the slice. So if we take, for example, a slice Z of I as our current predicted slice, we also take in consideration Z I plus 1 and the previous one, so Z I minus 1. So the structure is similar to the paper 1 structure, but then instead of only having one single encoder for this 2D plus time volume, we have 3 encoders that reduce the time dimension separately for each of the 2D plus time volume. And then they concatenate all the extracted feature at the end of the encoder. Plus, they will be decoded together in like a single decoder to actually produce a 2D image. The last approach is a 4D convolutional neural network, where the same input as the previous approach is being stacked together to create like a 4D tensor. This 4D tensor is fed to a series of 4D convolutional layers in order to reduce the time dimension and to reduce the dimension of the tensor. So this is done in like a single encoder, and everything is just being fed to a decoder through a skip connection in order to create a final image, predicted image. Sorry. Okay. In order to do that, we have created like a novel 4D convolutional layer, which is based on the idea that a 3D convolutional operation can be seen as like a sum of different 2D convolution operation. So what we try to do here is simulate a 4D convolution operation with the sum of multiple 3D convolution operation. And then we each of these 3D inputs is just fed to a 3D convolutional layer, and the output is just sum up together and just stacked to create a final output, which is simulate a 4D convolution operation. We perform a lot of experiments, and we saw that our models perform really good. Both the 3D plus time and GeNet, so approach 6 and approach 7 perform really good, and they are comparable or even better than our multi-input parametric maps model from paper 3. Just visually, these three show the prediction with the temporal convolution network, the one proposed in the literature, which, as you can see here, is not good. It's basically there is no good prediction, and it's just used for comparison for our next model, which is the MGNet, the one proposed in paper 1. Sorry, as you can see, even with different groups here. So the prediction are nice-ish, of course, but what I would like to focus on is this third figures, which show in the first row the multi-input parametric maps paper, the one they used parametric maps as input to the model, and the last two rows are the 3D plus time neural network, and the last one is the actual 4D convolution neural network. So the focus here, at least for my point of view, I can show you even with some, I don't know if I don't have any visual result, but I don't know if you can see my pointer. The most important thing is the two row using 3D plus time and 4D inputs are less prone to over segmentation or to create false area or false positive area in the prediction, plus the last model, the one with the 4D convolutional operations. It's really good to not predict ischemic area in patients that actually don't have ischemic stroke. So the last column here on the right. So the model shows us that it's less prone to over-segmentation and is more accurate in the segmentation of the areas. Moreover, instead of just using supervised method, we also try to use self-supervised approaches to actually understand if this medical condition can be tackled with self-supervised approach. And I would like to thank you both, Stine Hansen and Michael Kampmeyer, because during my, as most of you can know, during my staying at the UI team, I was under their supervision, and they helped me a lot for this work. So based on this, we were able to have like publish a paper, and the paper is self-supervised few-shot learning for ischemic stroke lesion segmentation. I'm going to present this, I think, next month. But basically, this paper, the highlights of this paper is we create a prototypical few-shot segmentation approach for the ischemic lesion, which is in this case both penumbra and core together. using only one annotated sample image during training. So we used parametric maps to generate the super voxel here, and then we use CT perfusion scan as the model input. So we try to understand if we can leverage in domain knowledge by extracting super voxel from the parametric maps can help us in this medical segmentation. So what we're trying to do is to use the CT scan from a patient that to pass through the same pre-processing step that I described before as input to our few-shot learning model, the ADNet, which is the anomaly detection network, firstly proposed by Steen Jansen. And we also trying to use color code genetic parametric maps as our input for our modified 3D Felsen-Swalp algorithm to extract supervoxel that help us the model focusing on different regions. So we experiment with two data sets, one with a full data set that I described before, and one only focusing on patients within the LVO group. We demonstrate the benefits of leveraging domain knowledge by comparing three different approaches. The one only using CT perfusion for supervoxel and input and models input, or using all the parametric maps for generating supervoxel and for as input. And we propose something that use parametric maps for generating supervoxel and CT perfusion as models input. So we show that the model perform our proposed model, which use domain knowledge, leveraging domain knowledge from the parametric maps and being used to CT perfusion scan, is actually perform really much better than just using a single domain image modality. Of course, this is not comparable with a supervised method, but it's only used to understand how the performance are for this. Plus, this might be really good, might be really helpful in a limited domain data setting, because might be that we don't have that amount of data in a for a medical domain problem. So visually, the results here are on the right, and we can see that the CT perfusion baseline bring unnecessary under or over segmentation in the prediction. The prediction are in green contour, while the actual annotated ground truth regions are in red. The parametric baseline tends instead to under segment the ischemic areas. So the results that we propose, so using parametric maps for generating supervoxel that will be support for our model, are actually really good compared to the other methods, but of course they're not comparable with supervised method, as I mentioned. But at the same time, this segmentation were obtained using only a single label slice, so it's might be an approach for future work to explore better, because might be useful in the future to just have like a limited data amount of data label, and then focusing more on the training part. In conclusion, yes, sorry for my long talk, but in conclusion, we have explored multiple approaches for precise segmentation of ischemic area, both core and penumbra, and this hyperperfused region altogether in patients suspected of acute ischemic stroke. And we saw that 4D MJNet can provide accurate segmentation using and exploiting the entire spatial temporal information from the CT scan. And we also saw that ADNet with domain leverage shows promising results in a limited label data setting.